Well, kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow Unit. It's my great pleasure to introduce Professor Alastair Hay, and he's had a career-long interest in antibiotic use in primary care, and with attempts to try and reduce the use of antibiotics in primary care. And he's one of the three leading researchers in the UK. So I'll just begin by thanking you, Bruce, for that very warm welcome. Just to say hello and good day to all of you, colleagues, primary healthcare, who are joining this evening. It's great that you're here. Thank you so much. New Zealand by birth, trained in medicine in Sheffield, that's the building on the left, and then as Bruce mentioned, a little bit of pediatrics at the Starship. I then trained as a GP and completed that training in '97 when I did a PhD at the University of Leicester, and after that I was appointed at the University of Bristol as a clinical lecturer, and I've sort of stayed with it ever since. I've now got a chair in primary care at the University of Bristol. That's my room, which I've been away from for 6 weeks now. Looking forward to getting back. And I also practice as a GP at Concord Medical Centre. I do a couple of clinics a week there. So here's the structure that I'm offering us this evening. So talking first of all about the evidence for the overuse of antibiotics in primary care and the consequences for that, of that, and the reasons for it. And then I'm generally a glass half full kind of person, so I'm going to talk a little bit about what I think we can do about it and offer some good news. And then finally, I'll talk a little bit about what I think is coming down the line towards us over the next 5-10 years, so that we can start to get our heads around that and be ready. And then we'll have a bit of time, I think, at the end for a summary and discussion, and plenty of questions and chats, I hope, will be great. So globally, we in primary care are responsible for the majority of all health service antibiotics prescribed, somewhere in the region of 3 quarters. This is UK data, but it's as true of New Zealand or Australia or the US, and indeed the developing world as well. So if there's a problem with prescribing, then I'm afraid it's up to us to be part of the solution. And we know that a high proportion of what we prescribe is inappropriate. And now that's dead easy to say in hindsight, and we'll come on to that in a minute. But at the moment, the evidence suggests that at least half of all antibiotics prescribed in primary care are inappropriate. That is not justifiable looking at the clinical data that goes with them. Sorry. Okay. And then that is also true in the UK.
All right.
Oh, we're all right.
Yeah, the camera's still picking me up, so I think I will just stay here.
So that is true. Inappropriate prescribing is also true in the UK. My guess is it will be true in New Zealand as well. I can't see why that could be any different. But here's some data. Mark Thomas is with us this evening. I'm really delighted to have met him this afternoon, and he's been working like a champion on this issue in New Zealand. And this is a paper that just shows that you're very unusual if you're a young child and you've not had an antibiotic by the age of 5 years. 1.9 courses on average per child per year. So that's a lot of antibiotics to be given out. So where does New Zealand stand in the grand scheme of things? So maybe not as good as you would like. We don't have the Australian data here. I know you'll be interested to see that. That's coming. The UK, yes, sure, we're a little bit better, but look how much more we've all got to go. So the Dutch are probably prescribing sort of in the region of 2/3 of what the UK is prescribing, and maybe around half of what New Zealand is prescribing. So we can all probably do a bit better. This is a slide that shows the relationship between overall outpatient antibiotic use and antibiotic resistance by nations. And if you can see the mouse here, what it shows is that as prescribing increases, so does resistance. So at a national level, nations that are using more antibiotics have higher rates of antimicrobial resistance. Now that's all good and well, But when I talk to clinicians, and increasingly the clinician group includes GPs, nurses, now in the UK, we're increasingly turning to pharmacists and also paramedics to help us. What I hear is, look, it's not me that's the problem here. In fact, I've never heard a single GP or clinician say, guys, I'm the one that's doing the bad prescribing. I'm always issuing broad spectrum antibiotics. I don't hear that ever. All I hear is it's not me, it's the neighboring practice. Or if I do prescribe more, it's because I'm seeing a different group of patients. Maybe I'm doing all of the on-call. That Professor Hay's never in the practice. So how on earth would he ever be able to even prescribe, let alone see a patient? So I think that really speaks to me about the importance of, if we are going to provide feedback to prescribers, that we do need to make it very specific to the type of prescriber involved. Anyhow, in response to this sort of message that I've heard over and over, myself and a number of us in Bristol decided that we would set about understanding what is the evidence for individual courses of antibiotics being prescribed in primary care and then leading to increased risk of AMR. And the short answer is, I'm afraid, each antibiotic course makes a difference. In fact, each tablet makes a difference. We can't shy away, I'm afraid. So here's one of the first studies. This was a systematic review published in the BMJ in 2010. And I'm not going to expect you to really follow the full detail here, but what it's showing is that your odds of having a resistant germ in your urine is increased fourfold if you've had any antibiotic within 1 month. If you've had an antibiotic within 3 months, then that increased risk is around 2.5-fold. Up to 6 months, it's still double. And even at 12 months, there's a small but definite signal that your chances of having a resistant microbe in your urine are increased. So it's not just at the population level that this is operating, it's actually at the individual patient level as well. That's also been demonstrated to be true in children. And this was a study, again, published in the BMJ, showing high rates of resistance to ampicillin in a large number of countries, including, you'll see, of course, New Zealand there, no different to the UK, Europe, or the US. This was a study that we published in the Journal of Antimicrobial Chemotherapy, showing that each individual trimethoprim tablet increases the odds of resistance by 1%. So 14 tablets, that's an increase of 14% in the odds of resistance. Here's a study looking at routine antibiotic use in primary care and MRSA in the nose. Again, you're more likely to have MRSA in your nose if you've had a recent course of antibiotics. And here's a study looking at people who were admitted to hospital with UTI, so severe UTI. Again, looking at recent use of antibiotics in primary care. If you've had a course, you're more likely to be admitted to hospital with a resistant than susceptible microbe. So clear relationships between prescribing and resistance at both population, but also individual patient level. And the consequences are clear, of course. So the most common one that we encounter in primary care is urinary tract infections. These, of course, are uncomfortable. And in the UK, 40 to 50% of all urinary infections are now resistant to trimethoprim. Trimethoprim, like New Zealand, is no longer our first line antibiotic for a urinary tract infection. And we know that UTIs, when they are caused by a resistant germ, are more severe, more costly, and are more likely to lead to hospital admission, which again is likely to be longer in duration and cost the health service more. The middle picture there is MRSA, which we've already discussed. And then, of course, at the very severe end of the spectrum, we've got life-threatening sepsis. This is a real concern in the UK. Like much of the world, we've got an aging population, and we're seeing increasing rates of bacteremia. Often it's urinary bacteremia, and an increasing proportion of those are also becoming resistant. So that's becoming a real problem. A problem that's recognised globally, so New Zealand recognises it. This is Australia's recent report, and here's Jim O'Neill, who led a global review of the costs of AMR and concluded that the global economy will be $10 trillion poorer for AMR by 2050. But it's not all bad news, and we've seen some progressive declining rates of prescribing in New Zealand, in the UK, in Australia. We don't quite know why it is. There may be some very positive results of things like public health campaigns to bring the public on board with the problem. It may be that clinicians are taking the whole thing more seriously, which is also good. In the UK, we've seen an increased use of nitrofurantoin, as you do in New Zealand for UTI first line, as opposed to trimethoprim. We've seen progressively reduced rates of trimethoprim use. And I wanted to share with you quickly some slides that are showing perhaps what that has resulted in. So this is the first slide. This shows obviously a map of England. Wales has been chopped off, and so has Scotland. So apologies to those of you who've got roots in Wales and Scotland. It's not personal, I can assure you. But each of the areas here is a healthcare board equivalent, or whatever your unit now of healthcare delivery is. And each of the areas is represented in terms of colour, in terms of the trimethoprim resistance in routinely submitted urinary tract infections. And each of the 6 following slides I'm going to show you represent years 2017, 18, 19, 20, 21, and 22. So really, I'm going to suggest that you watch the colours as we progress from 2017 through to 2022. And if the colours become lighter, it's because resistance rates are falling. So probably they are falling, I think. Most people would agree, and the statistics suggest that is the case. And that's really good news. It's not yet low enough for trimethoprim to become a first-line antibiotic yet, but it's something that I think is really encouraging. And it is probably, we can't be absolutely certain, but it is probably as a result of what primary care clinicians have been doing in the UK in the last sort of 8 years or so. So I think a big round of applause to our colleagues in the UK. So why are we overusing antibiotics? What is it all about? And I think Alexander Fleming, of course, first noticed that the mold was inhibiting the growth of streptococcus, and that mold was, in hindsight now we know, producing penicillin. Once it was upscaled in terms of manufacture, we were able to give it to soldiers on the battlefield and in World War II. And I think it's easy for us now in 2023 to forget what that was like for the global population in the 1940s and 50s. This was nothing short of miraculous. Soldiers who were dying previously were suddenly living. And people, of course, quickly started to think, well, what else, if it's good for sepsis and if it's good for really severe infections, what else is it going to be good for? And this is a slide that tries to sort of capture some of that. I refer to this as the dilution of indication and effect for the little that it's worth. But on the left-hand side here, you'll see that we've got conditions for which antibiotics are clearly beneficial. I don't think any of us would feel comfortable withholding an antibiotic from patients with these sorts of conditions. These in themselves were a step down in severity from the sepsis and the conditions that were killing soldiers on the battlefield. So already we'd, if you like, diluted the indication a step or two. But in the last 50 years or more, we've further and further diluted that indication so that we now find ourselves in a position where, rightly or wrongly, and probably wrongly, unfortunately, we are using antibiotics for infections that, on the whole, are simply not going to respond to them. And I think that the history here is important because we have inherited the attitudes of our grandparents who remember the miracle, the 20th century miracle that were antibiotics. And I think we've got to kind of start to push back a bit on that. So that's part, I think, of the reasons for overuse. If you're a parent, then being a good parent is about seeking healthcare in a timely manner. So parents will present children, and we will tend, I think, more often than not, to assume that the reason they've attended is because they're thinking they might need an antibiotic. The evidence is clear that we overestimate parents' expectation for antibiotics. So the way out of that is to be absolutely crystal clear in our consultations, if we possibly can, about identifying what is the patient or parent expectation. If you're an adult, then there are lots of reasons why you will be potentially consulting. You will, of course, be looking for ways to mitigate your symptoms. You will want to feel better because feeling ill with flu and chest infections and sinusitis and so on is pretty miserable. But the other thing that really pushes patient attendance is if they've received antibiotics in the past. We see this over and over and over, that whenever we use an antibiotic, we, if you like, reinforce that behavior. And if a patient has received an antibiotic, they will attribute their recovery to the antibiotic. And it's a really hard cycle to get out of. But the good news is that when we get out of it, we actually start to reduce attendance as well as reduce prescribing. So there are lots of benefits of this, as it were, two-sided coin. So why are we, as the clinicians, prescribing? So first off, I think we pretty badly let down by those who write our clinical guidance, because at the end of the day, we have to deal with the individual patient in front of us. And all of the guidance ultimately reverts to the common denominator of, if you're worried, prescribe. Well, that was the reason that I was looking at the guidance often in the first place. And I think that clinical guidelines need to kind of step up. Again, I think we've already started to do a good job, many of us, in our guideline groups, but I think the next step is to actually start to write guidance on diagnosis, so that we actually have a clear diagnosis before we have a treatment. And this is a classic example. I'm going to use one from NICE, which produced this traffic light a few years back, which was supposed to help us triage children into high amber, high red and amber intermediate or green low risk. And the idea was that if you saw a child in the amber or red groups, you would send them to hospital. Well, we've since looked at the proportion of children who are presenting with acute infections to primary care, and we've established that a third of them are in the red category, and the remaining 2/3 are in the amber category. So if NICE really wants us to send every single child to hospital that was in primary care, then I think we've slightly got it backwards. And so this is just an example of where I think guidance is letting us down. Why else are we prescribing? Well, we've got very clear evidence that we're prescribing because we don't want to be seen to have undertreated a patient who subsequently deteriorates. And it's easy in hindsight, of course, when patients come back to us and say, I ended up in hospital, doc, and I did come and see you and you didn't prescribe for me, and I'm blaming you. Doesn't feel good, and it might not be good if it goes to kind of medical legal type consequences. So I think many of us will find ourselves thinking, well, if I am in doubt, it's just simply safer to prescribe. So it's all a bit of a mess, and I think we're all struggling to figure out what is the best way out. So I said I was a glass half full kind of person. Let me see if I can bring that optimism to you. So first off, I'm going to talk about reducing overall prescribing, mainly around respiratory tract infections, but I think we've already established from the evidence that we are over-prescribing. There are two strategies. One is sort of reducing overall prescribing, and the other is trying to establish and identify who is most likely to benefit, and perhaps more importantly in primary care, who is least likely to benefit, because most of our patients in primary care will not benefit from antibiotics. So in terms of reducing overall prescribing, I think key here is what we are saying to the public generally. And as clinicians in primary care, we're on that interface between the health service and public health. So some of the messaging that we are giving to our patients is really important. Everybody experiences infections every year. At the moment, the best evidence we have is that about 8% of people choose to consult within any infection episode. So that seems great, except that that leaves 92% who are not currently consulting. And I think at the moment, the big risk as we change our health services is that we are pushing some of the green people into the amber zone. So public health messaging needs to be trying to keep people in the green zone. And this is an example of the public health messaging that we've been using in the UK, which may have been helping. It's difficult to prove, but certainly anecdotally, I find that patients are more aware of antibiotic resistance as a reason not to take antibiotics now than perhaps 20 years ago. Interestingly, I was saying earlier that we've seen some reductions in prescribing. This is a global phenomenon over the last few years, and it's also been further suppressed by COVID, which is good news. We hope that the recent outbreak of streptococcus in the UK, which has resulted in increased prescribing, is a bit of a blip, but it does seem that it is possible to reduce prescribing without doing harm. Here's a slide that shows, if you like, what the experts think we should be prescribing in relation to what we are currently actually prescribing. So if you take a condition like acute bronchitis, about 82% of all patients presented to primary care currently receive an antibiotic in the UK, and I'm guessing it's probably pretty similar in New Zealand. The experts would tell us that it should be nearer 10%, not 80%, 10%. And that's more or less true across the board for all of these conditions, that when we ask the experts, they say the prescribing should be considerably lower than it actually is. So is that safe? Is it safe to reduce prescribing? Here's a lovely study that was led by Martin Gulliford in London. And what he did was used natural variation in GP practice prescribing to look at whether that in any way was related to complications in their practice populations. And the complications that he was interested in, as you can imagine, were things like pneumonia, quinsy, mastoiditis, empyema. And what this slide shows is that certainly for mastoiditis, empyema, meningitis, and intracranial abscesses, practices that were prescribing lower amounts did not have higher rates of these complications. Now you'll see that there does appear to be a slight increase in rates of pneumonia and quinsy, and that is true, there were, but it's actually quite small. So for the average practice with 7,000 patients, that's UK, you'll have to kind of think about your own practices here in New Zealand. If a practice was to reduce their prescribing overall for RTIs by 10%, they might expect to see one additional case of pneumonia each year, and perhaps one additional case of quinsy each decade. So we're talking having to treat hundreds, if not thousands of patients to prevent these very rare events. Similarly, sepsis. Again, Martin Gulliford's group, finding that if you do similar sort of analyses looking at natural variation in practices, sepsis is an extremely uncommon event in people under the age of 25 if they've not had an antibiotic. Now, sepsis does increase with age and also frailty. So I think the message from this paper is that older, more frail patients we do need to be a little bit more careful with. But those who are under 65, and particularly those under 25, we're running really very low risks of sepsis if we are not prescribing. And of course, we want to keep the patient and the doctor happy. This is the ideal. It never happens, of course, not quite as beautifully as this. And what we do know about this sort of interaction where people are looking happy is that good communication skills will result in reduced prescribing. And here are some of the key things that I think clinicians can be perhaps thinking about. Number one, find out, having assessed the patient and determined what you think the diagnosis is, what is their expectation regarding antibiotics today? And I've found myself, like I'm sure many of us have, in that awkward place where you sort of say to the person, the patient, you know, what were you expecting I would do today? and they come back to you and say, well, you're the doctor, you tell me. So what I've now found myself doing is trying to play that a little bit more carefully. I have a few ideas as to what we could do today. So I'm kind of still keeping ownership and responsibility of the problem as your doctor, but what were you hoping I would do? And that will give you some insights as to what the patient agenda is, and that can get you out of jail endless times. Second, try and remember what is the natural history of the particular condition that the patient has. So if it's a chest infection, then you're really looking at 3 to 4 weeks before 90% of patients with chest infections will have recovered. And that's without, or indeed with, an antibiotic. Try and be both balanced in terms of what are the pros of an antibiotic. Now, for most respiratory infections, we're looking at maybe half a day or a day shorter symptoms out of illnesses that will often last 3 or 4 weeks. The cons of antibiotics, so all of the side effects that we can be aware of, and then of course AMR. And I hope that I've convinced you this evening again that what we are doing with our prescription pads in metaphor is actually making a difference to AMR. And then what can we do in terms of advising patients to look after themselves and mitigate their own symptoms? And I'll come back to some evidence that I think you may find helpful there. Safety netting, of course. So if things are going south or north, if you're in the south northern hemisphere, if things aren't going to plan or as hoped, what should the patient actually be looking out for? When do you want them to get back in touch with you? Is it things like breathlessness, which is a common symptom that I find myself talking about, or persisting high fever? So the safety netting that we put in place, that will, I think, get us out of jail when it comes to a patient that we perhaps not given the antibiotic to who's got a sore throat. If we are able to tell them to come back, for example, if they're struggling to swallow fluids, if it's becoming painful to swallow. And then, of course, asking that end question in the consultation about any questions, because that's the point where you discover that you've been barking up a completely different tree to the one that the patient thought you should do. So always useful to help. So communication, let's not kind of talk about all the high-tech stuff. Let's try and get the absolute core skills working really well, and I think that will help us. And of course, I totally understand that we're up against the clock. I'm just like that in my clinics, and it's hard work doing all of this if you're trying to do it in the 5-minute consult. So good communication skills can help reduce overall prescribing. Here's some really strong evidence that can help us not prescribe antibiotics to children who are presenting with chest infections, so lower respiratory tract infection, which is the most common clinical presentation that we see globally. And essentially, this is a trial that randomized children who had lower respiratory tract infection to either amoxicillin or placebo, and then looked at their outcomes in terms of how long their symptoms lasted, particularly if they were bad symptoms. And this is the curve, the graph that shows how closely the two groups behave to one another. So the blue line shows the children who received placebo. The red line shows the children who received the amoxicillin. This axis here is the proportion who have recovered, and along this axis here we've got time. So you can see that, the first thing you can see is that it takes a good 3 to 4 weeks before most children have recovered. And you can also see that these lines follow one another almost identically. In other words, children are not getting any better, any faster if we give them amoxicillin compared with an inactive substance. Really powerful evidence, I think, to bring to our consultations. Not only that, we looked at the common reasons why clinicians would say, well, look, I need to give this child an antibiotic. They've just had a very high fever. They might sound like they've got some sputum that they're trying to bring up. I can hear some abnormal chest signs. Maybe they're even a little bit short of breath. All of these things we looked at to see whether there was any suggestion that they were more likely to benefit from an antibiotic compared with the children who didn't have these things, and they weren't. The children who've got abnormal chest signs were no more likely to benefit than children who did. Here's another great study that I think can just offer us lots of reassurance when we're looking at adults this time with acute lower respiratory tract infection. And basically we're seeing the same thing. So these are adults who were given either amoxicillin or placebo, and you'll see once again, similar sort of graph, proportion who've recovered on this line, time on this line, absolutely following one another, dot for dot. So again, no benefit for people who've got acute lower respiratory tract infection, acute bronchitis in primary care. So that's all about kind of suppressing or trying to reduce prescribing for everybody. What about trying to get the antibiotics to the people who need them most, and perhaps just as importantly, or more importantly for us in primary care, keeping antibiotics away from the people who least need them? So here's a controversial figure from the UK. I mentioned him earlier as being the author of one of the reports into AMR. Jim O'Neill also has said that no antibiotics should be given without a diagnostic test. Now, I don't actually share his view, and I've tried to engage him in a discussion with that. And I think there are various reasons why I don't necessarily agree, but I kind of understand where he's coming from. What I think he, in a way, is saying is that every single prescription should be justified, and ideally it needs to have good, sound evidence to justify it. So here, for example, is one way in which we can target antibiotics. Now, this is a slide showing NICE's recommendation for antibiotic treatment of sore throat. And it's recommending that people should either use the fever pain score or the Centaur score. Now, I imagine Centaur is probably reasonably well known here. You're using them.
I tend to use the McIsaac version of it from Canada and Toronto.
Okay. So the McIsaac is an adaptation of the Centaur, and fever pain is another score which has some same constituents, and it's also got some different ones. I personally think that the fever pain score is slightly superior to the Centaur. I don't know that I've seen the data for the McIsaac, but the principle here is that we try and target the antibiotics towards the patients who've got the highest scores. And we try and keep antibiotics away from the patients who have got the lowest scores. So here we're saying, NICE is saying, you know, if you score 0 or 1 on fever pain, or if you score 0, 1 or 2 on Centaur, then do not give an antibiotic. And actually, when you look at the way the patient groups break down, this is the majority group in primary care. This is actually the minority group in primary care. So most of our patients, we probably shouldn't be giving an antibiotic to, and this is a tool that we can use. Now, those of you who are wondering what is fever pain, if you were to put it in your search engine now, you would find it very quickly. I think fever, P-A-I-N. The constituents are here, and it's just a simple 1 point for each score, for each element, and then Centaur is also represented there, and I think these slides will be available if you are wanting to look at this. Point of care testing, I think, is coming our way. This is CRP, C-reactive protein, which is, as you know, an acute phase reactant. And NICE recommended that GPs and primary care clinicians in the UK should be using this to help distinguish patients who, to distinguish between pneumonia and acute lower respiratory infection in patients in primary care. But we've completely ignored that guidance. Nobody really, well, I shouldn't say nobody, very few clinicians in the UK are using CRP. And it begs quite a few questions as to what that is, which we can come back to if we want to. But the principle here is good, that we might want to, in the future, potentially use point of care testing to help us guide treatment. The big risk, though, is that we inadvertently find ourselves pushing more people who are currently green into the amber zone, because not only are they now wanting to come to us because they think they need an antibiotic, but they're going to start coming to us because they think they need that point of care test too. So we've got to handle that really carefully. So we've talked about reducing overall prescribing. We've talked about targeting prescribing. What else can we offer our patients? If we're not offering them an antibiotic, what else can we offer them? And we often, of course, talk about taking fluids and resting. There's very little evidence to support it, but I think it makes a lot of sense to do that. And I certainly advise most of my patients that rest is a really important element of recovery. often I think that patients will be sort of looking to us to maybe prescribe an antibiotic so that they can keep going, so that they can keep meeting their busy lives and heavy responsibilities. But often I think our bodies are simply trying to say to us, we need to rest. What else can we do? Well, here's some evidence from a study that I led a few years ago that was published in the BMJ. This is the study logo. His name is Pitch. The item in his bill is not a cigarette. I mean, in hindsight, you think maybe that wasn't the best logo. It is supposed to be a thermometer because Pitch the duck has got a fever. And what we did was answer the question regarding whether two antipyretics, paracetamol and ibuprofen, offer any additional benefit for children over either paracetamol or ibuprofen alone. And the way we did this was to randomize the children into 3 groups. So they either received each of the therapies on their own or they had the 2 therapies together. And then the parents, along with some support from a research nurse team, helped the child to keep this vest on with a data logger in a little pocket, which then had a probe going under the child's arm that was measuring the child's temperature every 30 seconds for 24 hours. Now, what that did was allow us to produce a very granular graph showing over time, first 24 hours after the children had been given the different treatments, what was happening to their temperatures. And you can see here that the children who were given both paracetamol and ibuprofen did have sustained lower temperatures than children who were given either medicine on their own. In fact, the numbers, when you crunch them, show that if you give the child ibuprofen, the fever comes down faster than if you give them paracetamol, and that after a few hours, it's not really making much difference if you give them paracetamol or ibuprofen, but it is making a difference if you give them both. Now, we don't recommend treating children's fever per se. The fever doesn't require any treatment. In fact, the fever may be conferring some benefits to the child over the infecting microbe. So fever is not the goal here, actually. It's really more about the child's discomfort. And I think that's where most of us would say, yes, if the child's still in discomfort, having given them one, then it may be reasonable to give them the other and perhaps alternate them. That was published in the BMJ, as I say, a few years back. And then another topic of real concern, particularly for parents, and this is a child who has not just had Sesame Street turned off. Is Sesame Street something?
I don't think it's on anymore, but
No.
It might be Peppa Pig now.
Peppa Pig. So
thanks to Boris.
Okay, so Peppa Pig, no, this is not a child who's just had the telly switched off. No, this is a child with otitis media. And of course, this is an extremely painful condition. And we ran a study a few years back to see whether a topical anaesthetic drop could relieve the pain and also reduce parents' need or desire to resort to antibiotic use for children with otitis media and pain. And in fact, it was very effective at reducing antibiotic consumption, and it was also effective in reducing pain. And I'm very pleased that NICE has now recommended that children who are receiving or who have otitis media and who are not thought to require an antibiotic, and that is the majority of children with otitis media, the majority do not need an antibiotic, but it may be that they would benefit from an anaesthetic ear drop. And I'm waiting to see how much this gets taken up in the next few years in the UK. Maybe it'll also become something that happens here in New Zealand. And then maybe one thing that we don't do for people with acute lower respiratory tract infection, we ran a trial to assess whether adults with acute lower respiratory tract infection but no previous asthma or known asthma, whether they would benefit from oral steroids. Now, the purpose here was really to understand whether oral steroids or indeed inhaled steroids might help them. And the answer, here's the same sort of graph again, showing recovery in the prednisolone. It was 50 milligrams a day for 5 days versus placebo. Again, proportion recovering and time. And you'll see the 2 lines are just following. So I think the message here is very clear. We should not be using prednisolone. Hopefully most of us are not anyway, but you'd be surprised in some parts of the world, people are turning to prednisolone to see if it will help. It won't, it definitively won't. And I think that also means that things like inhaled corticosteroids, steroids are very unlikely to help. And that seems to be what the evidence tells us as well. So that's a little bit on symptom mitigation. What do we think is coming down the line? I think I'm in the last sort of 5 minutes or so. Is that right, Bruce?
We're fine, yeah.
So if we're going to reduce the overall burden of infection in society and the proportion or the number, the absolute number who are seeking care from primary care, then infection prevention and control is important. We know that hand washing prevents infection transmission, so that's something that we'll keep doing even after the pandemic. Vaccination, of course, has proven absolutely life-saving and economy-saving in the pandemic, but there are new vaccines coming down the line. For example, RSV. I think there will be a vaccine emerging quite soon for children, and that's going to make a big difference, I think, to what we are seeing in primary care. I think we're going to see increasing use of surfaces that have inherent antimicrobial activity, even if it's not necessarily via antibiotics. So those, I think, are starting to emerge. I'm starting to see some of those appearing in some hotels. Air purification, this is a hot potato. We've got very clear evidence that they reduce the microbial load in the air, but there's zero evidence to date that they actually, that reduction leads to improvement in human health. I'm leading a trial that is seeking to establish whether they do reduce infection rates in residents and care homes. So that trial is due to report in a couple of years. I've mentioned NICE, and I think the need to improve clinical guidance, and that may be around diagnosis, but also I think they need to be much more accessible. I understand at the moment that Bruce, you can't access, for example.
We have trouble with some of them, which is see what you can do in the UK.
Yep.
Influence on
Okay, see if we can help there. So, and I think also bringing the decision support right into the clinic would also help. So I've been saying to NICE, you know, why can't I just use a single click on my computer to get to the relevant guidance when I put a patient diagnosis in, for example? I think we need to continue to monitor antibiotic use, and I think for me a really powerful tool will be if we can provide all prescribers with individual feedback on their prescribing in relation to other prescribers who are like them. I don't know if I'm a good prescriber. I know my practice is a good prescriber, but I might be the one prescriber in my practice that is actually keeping things, you know, worse than they would have been, and that all my colleagues are doing really well. And I think that's a pretty poor place to be. We've mentioned Jim O'Neill and him saying about diagnostic testing. I think we're going to see point of care testing coming down and test quite quickly now. I'm already starting to get patients phone me saying that they've done a test for X or Y. What am I going to do about it? I don't know if that's ever happened to you yet, Bruce. But I think I'm predicting that that's going to increasingly happen, partly driven by the point of care test manufacturers. There's an enormous amount of money to be made in point of care testing that they are going to really want to get in.
We have so few here that they don't, patients wouldn't ask for them, and they do the red tests at home, which there are some might go and ask for red tests, but they're freely available.
Yeah. So I think there'll be point of care tests for things like streptococcus being made available, for sexually transmitted infections, and so on. So, and we're also doing research to look at the impact of rapid testing for microbes in primary care. So results to follow. I think antivirals are coming our way. I think it won't be long before we start to have not just oseltamivir, which we can use for some groups of patients who seem to benefit with GP diagnosed flu, but then maybe further antiviral treatments becoming available. So I think all of this is coming down the line. Antibiotics or antibacterials, point of care tests, and antivirals. And then the big thing that we're seeing in the UK is a real diversification of who is managing minor illness. I don't know how this sits in New Zealand, but in the UK, we've got nurses, pharmacists, and paramedics helping us. And I really don't think we know who's who's best at it or what the needs are of those different clinical groups in supporting good antimicrobial stewardship. But one thing that really worries me is that all of these interventions might make us more accessible. That may be a good thing. But what we don't want to do is to drive the proportion who are currently green into primary care for the wrong reasons. We want to see the people who need to see us, but not necessarily the ones who are not going to benefit. So I think that's a big concern for us moving forward. So we're getting towards the end, and I'm looking forward to the discussion. In summary, what we've been talking about is very strong evidence that we remain overusers of antibiotics in primary care, and that as the majority prescribers of health service antibiotics, we've got to step up and take responsibility for the problem, and that the consequences are clear in terms of definite links with AMR. And then we've talked a bit about reducing overall prescribing and how that could be achieved. We've talked about targeted treatment using things like clinical prediction rules, possibly using point of care tests in the future. We've talked a bit about if you're going to give them something, then what is it that you can give them that's not an antibiotic? So that might include things like an anaesthetic eardrop for a child that's in a lot of pain, or an antibiotic isn't going to help them. And then we've had a quick look at what might be coming down the line as us in the future. So I'm going to pause there, and as I say, I'm really looking forward to the discussion and all of your questions. So thank you for listening.
Okay, so I was just going to start the questions, Alastair. So you showed that the Dutch are doing better than anybody else. When I talked to Chris Van Weel from Nijmegen, he thought they still prescribe too much. So do you have a view on that? Are they prescribing too much, or do you think what they're prescribing is about right?
No, I think the evidence is that they can go lower. And I think that none of us probably in the so-called developed world have gotten down to the point which is right yet. So I think we can all do better. I think, you know, the question, I suppose, underlying what you've asked in a way, Bruce, is how low can we go?
Yeah.
So I don't think any of us fully know the answer to that question. I presented a little bit of data that shows that, you know, as you reduce it, you can expect to see small increases, literally tiny increases in rates of pneumonia and quinsy. But there seems to be a lot further yet that we can go. We need to keep monitoring it. And in the UK, certainly, and I guess here as well, we've got Sentinel surveillance systems looking for a signal that we've gone too low. We're looking constantly at admissions for quinsy and pneumonia and so on.
One of the issues I remind my colleagues about is in some of those like otitis media trials, they remove the very sick kids. And I think we always have to be a little bit cautious of the very sick, very high fever, looks very toxic, not functioning very well, that they probably do need an antibiotic. And I guess that's the exception that you talk about, but that probably is safe practice, because that is a scary situation. There's a few comments here about the rheumatic fever thing. Of course, you don't have rheumatic fever in the UK, and we do. So the sore throat thing is a little bit tricky here. And for the equity thing, we target Maori and Pacific children, much more likely to give antibiotics there. But we have a topical antibiotic called pimafukort here. I don't know if you have it in the UK. It's got an antibiotic in it, and it's got a steroid and a anti-yeast. And there are 180,000 prescriptions a year for so-called infective eczema. And I think that's a lot of infected eczema.
It is,
I would say.
And most eczema, in my experience, responds quite well to topical steroid only.
No, that's my. I try and get my registrars not to give antibiotics, and they heed that. Your view about pharmacy prescribing?
Yeah, this is a really hot issue in the UK. I think the sense is that people can't get access to their GPs. So can the pharmacist step in? I think it makes a lot of sense from a patient point of view. I think at the moment, the evidence is just not there as to whether it's the right thing to be doing. And UTI is obviously different to RTI. I think my sense is that most people who have a confirmed urinary tract infection probably do need an antibiotic. I don't think that's really too much in doubt. But the real question in my mind is when somebody, and it's typically, of course, a woman, and if they've got uncomplicated sort of cystitis type symptoms, a very high proportion of those women, if you do culture their urine, they don't meet the UTI threshold. In fact, it's about 40% do not have a laboratory confirmed UTI. So if you think back to that triangle, the pyramid, and you've probably got a proportion of women, mainly women, of course, who are staying in the green zone, they perhaps don't attend. If we make ourselves perhaps too accessible, I don't know if that's possible, but we might find ourselves pushing people into the amber zone. We might find ourselves then issuing more antibiotics, and there may be an even greater probability that those people don't even have a UTI. So it's difficult. I think we've got access problems, and we need to treat our patients. We need to meet their needs, but we don't know yet whether we're doing the right thing by making ourselves more accessible. I don't know.
A question here about evidence of back pocket prescription. This has been Paul Little's sort of territory, hasn't it?
Yeah.
And the evidence is they do reduce, although we did the one on common cold, and still 50% of people pick them up. I mean, in the UK, you make them come back. We give them the prescription. I think in Paul's study, you had to come back to get the prescription, which wouldn't go down very well in New Zealand because people have to pay another fee to come. So in our system, we tend to give the prescription and say, I sometimes post-date it. I say, well, write back pocket prescription on it. So the pharmacist, but I know a lot of patients go straight downstairs and get the antibiotics. So, but it's interesting in the otitis media studies that they had the biggest reduction. So parents were less likely to give antibiotics to their kids than adults. I don't know if you have a view on that.
So the evidence from the trials is very clear, isn't it?
Yeah.
That if you use the delayed or back pocket or standby prescription strategy, it will reduce overall use. My view, to be honest, is that I don't think it should be used often. I think it's probably quite a good strategy to use. If you've got a patient where, you know, you really are just slightly concerned, you're not absolutely certain whether they need the antibiotic or not. Maybe they are a little bit febrile, maybe they do have a little bit more of a tachycardia than you're really comfortable with. I think it's actually reasonable to give them a delayed prescription, because in that sort of situation, I think the evidence suggests that people will be quite sensible. And if they are getting worse, which is one of the criteria that we're supposed to say or emphasize when we use the delayed prescription, then I think they probably will take it. That they will, you know, self-select perhaps the folk who are most likely to benefit. But I don't like it as a broad brush strategy, if I'm honest, because I just think it's putting antibiotics into the system. As we make them harder to get, people are more likely to store them away, keep them for a rainy day, and I don't think we really want that to be happening.
No.
So I'm not a fan of it being used frequently.
Yeah, no, and I've come, even though I've done some research on it, my view is that we should be saying, no, I don't think you need antibiotics at the moment, but make it easier. And, you know, in our clinic, we'll say we'll come back and we will see you without charge. That can be more difficult in some of the areas where there's bigger fees. We're a low cost clinic, so to be and we prefer to do that to get people to come back. But just a question there about now, what was the recent strep infections in the UK? Where were they? What organ were they affecting? And
yeah, so what happened there was we had an earlier than normal increase in invasive strep A infections, both in adults and children. I didn't see the subsequent data, but at the point where public health were starting to get bounced into making statements to the press about it, the rates were no higher than they had been historically. They were simply earlier in the season than they had been past. And I think that my interpretation of that is that we were emerging from COVID and from lockdowns. People's immunity, children's immunity hadn't been primed in the same way as it has been in the past. And so we have been responding in a different way to the infections that we would normally be seeing at other times of the year. We saw this as well with RSV. We had RSV in the summer in the UK this last year. So I'm think we got bounced a bit into prescribing more, and we definitely saw, that green and amber pyramid I was displaying earlier. We definitely saw lots of people who were in the green zone normally being pushed into the amber zone. We were totally overwhelmed with demand. We could not meet the demand for assessments of children. And that was true in primary care and in the emergency departments and in the pediatric assessment centres. We were all totally flattened by it. And the paradox is that made it harder for us to detect the child who actually had the invasive strep.
Right, because the worried well are coming in.
Correct.
Yeah. This is a question about otitis media. Here, we've actually had a reduction in otitis media to the point that I now have trouble getting a medical student to see an acute otitis media in their 4-week run. Like 20 years ago, they would have seen a whole lot of them. And I presume the same thing's happened in the UK, hasn't it?
I'm not aware of the data, if I'm honest.
It's going to be immunisation.
I think that's streptococcal immunisation.
Yeah, we do pneumococcal and H flu vaccination here, and there's some evidence that it comes down. Question about what's the cutoff for CRP to indicate bacterial infection?
So in the trials, they use, I believe, 100 as the indicator for giving an immediate prescription, and they say between 40 and 100 should be a delayed prescription. Less than 40, don't prescribe. That's slightly from memory. So whoever's asking that question, it's a good question, thank you. But you might want to just double check that.
That's pretty high in my experience. You'd have a rip roaring something or other somewhere. Yeah, and it probably clinically pretty obvious, I would say.
I agree.
I think if you have to, believe the patient rather than the blood test.
I agree, and as I've alluded to before, if we start doing CRP on a lot of people, they are going to come to expect us to do that again in the future. So that's a kind of another rod for our backs.
So they want us to speak louder. So I don't know whether it's you or me, but we'll see how we go. So we've done that one. The audio is very quiet. Okay, don't know why that is. Sorry about that. We will put our outside voices on. Volume is good. Okay, so it may be at your end then, folks. Our IT person's saying we're okay. It's not us, it's you. So sorry about that. I work with a GP who has already started point of care CRP testing and eardrops for pain relief instead of antibiotics. Perhaps that person could tell us how easy it is to get the eardrops for. Do they come in a oral gin that was the name of your
Oral Gan, which is an Australian brand.
Sounds like a train, doesn't it? The Gan. It's the one that goes from Adelaide to Northern Territory. Same person here. This is a New Zealand practice. Now, hang on, I don't know. Sorry, you'll just have to rewrite that, Nicole. We can't. Your questions are separated, so sorry about that. I've got a long one there. Do we have anaesthetic drops in New Zealand? I don't know whether you can just put some lidocaine in. I'm not sure. I would be interested.
I would be a wee bit cautious about that.
Rather a set dose of 1% lidocaine, which works wonderfully, says. Okay. Yeah. That's interesting. Might be quite good acutely when you've got a kid in the office screaming their head off,
Just be aware that there are some, and it's one of these sort of situations where a very, very rare side effect of lignocaine or one of the topical anaesthetics, particularly if the eardrum is perforated. So it's a contraindication if the eardrum is perforated, do not use the drops then. If you're seeing pus come out of the ear, don't use drops. But is also in children who are susceptible to GDP deficiency. Somebody will help me here. One of the
glycogen storage.
Or no, it's one of the hemoglobinopathies, I think.
Oh, okay.
Because there is a very rare problem with methemoglobinemia in some groups. So have a little look at that. If you're very interested, you can look up the publication. I'm the first author for the so-called CEDAR trial. All the details are in there, as in the tree.
Oh, CEDAR.
Yeah.
Okay, now Liz comes up with a question. Managing your colleagues who overuse antibiotics and prednisone for URTI. You may be the only doc in the practice trying to reduce prescribing. So it's the politics, the little p politics in the clinic, aren't they?
Liz, you have my sympathy. I'm in the same situation. I think we have to play our cards very carefully. We've only really got kind of, I mean, you know, if we start banging a drum, we won't be listened to very quickly. So yeah, I think tolerate it for as long as you can. Try and set the great example that I'm sure you are. Hopefully the system will step in at some point and start to provide all prescribers with the feedback that I was describing. That should help. And just occasionally you might get that moment where that individual, that colleague is respected. And they may be saying to you, you know, maybe they've noticed the way you prescribe, and they want to ask you, you know, how do you cope with that? Maybe is it that you're better at tolerating uncertainty than they are, perhaps. So just be ready for the opportunities when it arrives to say your bit.
You have to know why somebody has given an antibiotic, don't you? Because I know, you know, if their last patient died of septicemia, you can imagine the next 20 patients are going to get an antibiotic.
Okay.
You know, there's always, it's called the chagrin factor. I think David Sackett came up with that.
Yeah.
Now, Mark Thomas may know this. In New Zealand, are our prescribing rates different for each ethnic group? I would be almost certainly think that's the case. If Mark's still there, Mark may want to come onto the screen and answer that, because he most certainly would know that. So there are differences for everything else. So okay.
Yes, I mean, if Mark's not here, then I've seen his studies, and yes, the prescribing rates are higher. That may be appropriate, of course, as we've just been discussing.
That's right. That's right. I think that's true. But yes, Gumari do get a lot more. I've seen some data on that. Anyway, sorry, I've got the NatMetka data, which is old. Where do paramedics fit in on antibiotic administration?
Well, in the UK, they are becoming part of the frontline team. So they are becoming independent prescribers, making decisions just like the rest of us. So I think we need to support them in the same way we need to support all of our colleagues.
Melissa, question, you speak of cellulitis and skin infection. Is there a role for topical antibiotics? I'd say no. BPAC guidelines say oral antibiotics. The only use, the recommended use for topical antibiotics in New Zealand now is for nasal carriage elimination. The one small problem with that, of course, is the companies may stop providing them. That's a bit of a risk, but yeah, no role for. I mean, occasionally I've seen a few little impetigos and put a topical antibiotic on, but that's really we should be giving oral antibiotics.
But also cellulitis,
yeah,
but not for impetigo necessarily. No.
And Mark would say that you can probably 5 days is enough. The redness of cellulitis is often part of the condition rather than active infection. So, and if you keep giving 7 or 10 days, you're never going to know if 5 days is enough.
And I was going to make exactly the same point. I think, I mean, we don't actually know how long the redness of cellulitis lasts. No one has yet done that study.
Yep.
My experience is it's probably at least 3 weeks. So if the patient's coming back to you after a week of antibiotics, or as you say, 5 days, you are not going to see a resolved infection. You're not going to see a normal leg. And I think the thing to do is to try and anticipate that a little bit like we do with lower respiratory tract infection and say, look, you know, your infection and your symptoms are going to last perhaps 3 or 4 weeks. With cellulitis, we know there is a role for antibiotics, so we do think you should be treating it, but you shouldn't expect all of your symptoms to have settled by the end of the course.
Yes, I certainly do that with cough. I say this cough could last up to 4 weeks because that's the evidence. And if it's still there in 8 weeks, we'll perhaps order a chest X-ray. You know, so really downplay the expectations. Otherwise, they're back in 2 days saying my cough's still here, give me an antibiotic. Question about hip breaks as part of UTI management. I don't know. That may be funded in New Zealand. Somebody could correct me on that. What is your view on that?
What is hip break? Is that
I think it is. I'll look.
I think there's just been a trial showing that it is effective in preventing UTI, but not for treating UTI. I think. I'm part of a group that's just doing a trial of D-mannose to see if that prevents urinary tract infection. And I could give you a little global sneak preview if you want.
Okay. Hiprix, New Zealand's only fully funded urinary tract antibacterial. Okay, so what is it?
I'll perhaps go on to the next question while you're looking.
Okay.
If you like.
Okay.
Do you think that farming antibiotic use plays a big role in increasing resistance? Yes, is the answer. It does. But it's not a reason for us not to try and do our bit for the human community. The UK data is that per kilogram, which is a slightly nasty way of thinking of humans, but per kilogram, veterinary use is similar to human use.
I did a back of the napkin estimate of that one, so
Okay.
I've got about the same
Okay.
figures. Yeah, it's pretty crude. It's hexamine piperate. So I think that's what
Methenamine. Yeah, I'm
Hexamine.
pretty sure that that's just been published in the BMJ showing it's effective literally
Okay.
in the last 6 or 12 months.
I will look that up and might make that a gem actually, Hiprix.
Yeah. Nice study.
Yeah, BMJ. Okay, I might have missed that one, so that's good. The farming antibiotic, yep, it's farms not good. Are there studies on the impact of telehealth on antibiotic prescribing and resistance?
Well, I mean, the thing we've learned about telehealth has primarily arisen from the pandemic in the UK. And I think what we can't really do is distinguish what was doing what. So we saw with the lockdowns, we saw just complete suppression of transmission of infections. So a lot of us didn't have any respiratory infections, for example, for several months. We saw reduced demand from primary care. So we had fewer people going from the green into the amber zone. And as a result, we had lower prescribing overall. The rates for prescribing were more or less the same if you look at per condition for respiratory tract infections. So although I think we saw some prescribing going on because you couldn't get to see the patient easily, or you were concerned that you didn't want to bring them into the clinic, and so it was a kind of, well, I'll prescribe just in case, that doesn't seem to have translated into big changes. But I think we're waiting to see what happens now post-pandemic. Certainly, as you guys enter your Southern Hemisphere winter, we're going to be watching that very closely.
The answer about Oralgen looks like it is available. And it's $14.99, which would be too much for many of my patients, parents with young children. A number of the pharmacies have it, which I think would. But why was Oralgen taken off the market? Don't know.
So there was, it was quite. We did a lot of looking into this, and it was very difficult to determine precisely why Oralgen was taken off the market.
Well, that's not on the market anymore.
It was removed in the US.
All right.
So
it did not include adequate directions for use. FDA removed it in 2011. It looks like it may be available here. Could somebody just flick a thing if they've used it in the last few months? That would be very good. Can we get a copy link of the antibiotic versus placebo graphs helpful to a limited antibiotic? What papers would they?
So if
we could,
can we get the slides? Send the slides out?
That's tricky because there's copyright issues with.
They were both published in the Lancet. And Paul Little was the first author on both studies. So
yeah, I have.
One is Lancet and one is Lancet Infectious Diseases.
Yeah, I've written a gem about that. But if you want to email me, and I can find the paper for you and send it to you. But the two curves sort of go down together. There's a slight benefit in the antibiotic group in the middle, isn't there? And I remember us asking Paul Little this when he did a session with us. He thinks there may be the odd person with a little localized pneumonia, which doesn't show up clinically. They're not sick with a pneumonia, but the antibiotics deal to that. And so there's a very tiny benefit, but that would probably be a minority of patients. and it doesn't make any difference at 7 days. So,
And we know that it's not going to reduce complications in terms of untreated pneumonia.
okay, expecting antibiotics for their children that has lasted for more than a week.
So here I think we're back to, trying to give accurate information to parents about what to expect. So a child who's got a cough with a respiratory tract infection, that's like an adult. It'll be 3 to 4 weeks before 90% is resolved. For ear infections, it's 8 days before 90% have resolved. For the common cold, it's 10 days. And all of this information is available. If you were to look up the BMJ, and then Matthew Thompson was the first author on one of the papers that I've been citing there, that's got all that natural history information in it.
Oh, that sounds
I
good.
think that's 2013 from memory. Matthew Thompson, BMJ.
Thompson
Thompson, THOMPSON.
in BMJ. Okay,
Yeah.
that would be a nice one.
Yeah.
That'll make a nice gem, I think. I elaborate the purpose of point of care CRP, and is it worthwhile?
I'm a little bit unsure about it, if I'm honest. So prevalence of elevated CRP in primary care populations is low. And if you look at the trial data, it's about 1 in 10 have an elevated CRP. So 9 times out of 10, it's going to fall by chance on a do not prescribe, that side of the fence. And I'm not sure, I think it may simply be working as a kind of arbiter in the consultation. The patient and the doctor are both wondering whether an antibiotic is necessary. They're not quite sure. So we'll use the CRP as the kind of arbiter, and 9 times out of 10, it will fall in favor of do not prescribe. So is that really being used as a diagnostic test? Is that being used as some sort of arbiter? It's a bit strange, I think. I think we need to understand how it's working. It's certainly disproportionate to its diagnostic performance. So I personally don't think we've got the evidence yet to justify it. And I'm worried that if we use it a lot, our patients will come to expect it.
I think I have seen a trial where they compared CRP to clinical things, and there wasn't much difference. But
that's true. Communication skills, and I mentioned that, it gives you similar effects. So if we can get our communication skills really humming, I think that'll help us.
Interesting, you and I use the passive voice. Is there something you're hoping I can do for you today? That's the one I use, which is a variation of, what do you say? You say,
I say I've got some ideas as to what we could do today, but I just wanted to check in what were you hoping I would do. That diverts the person who says, well, you're the doctor, you tell me. You get that slightly sarky, response sometimes if you say, well, what were you hoping you would do?
is there a study of data showing reduced use of antibiotics? We did with the common cold, we showed a 50% reduction, but this still means 50% of people are getting antibiotic. And although I did that trial, I rarely use back pocket prescriptions. It's only if I'm in a complete locked horns with the patient and I'm not getting anywhere and they're banging their fists, I say, okay, let's try the late prescription. And I often check whether they picked it up, and it's usually they picked it up, but we can check whether they picked it up an hour later.
Yeah.
And go to a thing called TZ. Okay, so we're coming near the end of time, and we've got 70 questions. So unfortunately, we're not going to get anywhere near close to the questions. So I think Google tells me Origin available live pharmacy $15.99. Yep. Thanks, Helen. That's good. G6PD was, I think.
Yes, thank you very much.
Yeah.
Whoever you are, you're anonymous on my screen. Yes, that's a concern with organ, so be careful.
So I'm going to call it to a close now. I'm sorry for those of you who haven't got our questions. We will perhaps get Alastair to come back and we could actually do just a Q&A. It'd be morning time for you and night time for us.
Yeah.
But I think this has been fabulous. And when we get this many questions, we know this is a very good topic.
Thank you, Bruce. And thank you everybody for listening in. It's great to have been, I hope, a help, and good luck with all of your stewardship activities.